Okay, so I welcome everyone to this instruction course, Pulse and Pitfall of in Glaucoma Surgery. First of all, I would like to thank AIOS Scientific Committee for selecting this IC. So we have three expert speakers here, Dr. Sagar Bhargav, Dr. Devashish Chakravarti, and me himself. We are talking about Pulse and Pitfalls in Glaucoma Surgery. First of all, let me introduce our speakers. Our first speaker is Dr. Sagar Bhargav, who is a senior consultant in glaucoma and cataract refractive surgery in Netralyam and BBI Foundation. He is also director of Netralyam. He has completed his MS and MBBS from Government Medical College Aurangabad, and he was a university topper. He was a consultant in Chennai, Shanghai, Kolkata for a total span of 9 years. He has started LASIK work in Shankar Kolkata and was forced to use femtosecond LASIK and bleedless LASIK in East. He has been actively involved as speaker and panelist in many of the academic activities at state and national level. Our next speaker is Dr. Devashish Chakravarti, who is MS and done a fellowship in glaucoma from LV Prashant. He is a consultant at Center of Sight in Kolkata. He has conducted several IC and chief instructor of AIOS and has published several books and chapters. He has several articles in peer-reviewed journals. So we'll start the topic right away. So first, I would like to introduce the topic. It is the first. We are going to discuss about the surgical approach of glaucoma. We are going to discuss about trabeculectomy, valve implantation, and also the management of glaucoma, surgical management of glaucoma in childhood, in children. So first is I have declare that I have nil financial interest in any of the procedure or technology I have is shown in my presentation. Now, decision for taking a surgical decision whether patient needs a surgery or not should be considered on the basis of risk-benefit ratio of the patient. We have to consider whether the risk of doing surgery is more or less than risk of not doing surgery. If the risk of doing surgery is more, we should avoid any surgical procedure. Although sometimes a lower IOP generally considered to be beneficial to the patient, there is a risk of vision loss after surgery. So risk of surgery must outweigh the risk of vision loss without surgery. So we have to evaluate and also take in consideration the role of IOP in taking decision for surgery. IOP reduction, even if IOP sometimes IOP measurements become normal in office visits, the patient may be suffering from normal tension glaucoma, may require surgery. So IOP measurement should be done at several occasions before deciding whether the patients need a glaucoma surgery or not. When IOP is markedly elevated, then a single measurement of IOP is sufficient to decide. When IOP is borderline and there are field changes, there are changes, then we have to do a follow-up before deciding the patient. If there is advanced damage and damage threatening central vision and patient sees a significantly lower IOP than early disease, then we must consider surgical intervention for those patients. Very important is to see whether the glaucoma is progressing or not. If the glaucoma is progressing and it is well documented on field examination, we have to consider surgery for the patient, and we have to aim to stop the progression of the disease. Some patients have a greater risk of the progression of disease. For those patients, the threshold of surgery should be lowered, and we can go a little. We can decide a little fast before planning surgery. Patients with advanced damage, we can right away plan the glaucoma intervention if the pressure is not controlled and we think that the glaucoma is going to progress. There are certain risk factors of glaucoma in which early surgery may be needed, like sometimes older age with advanced glaucoma, patients with diabetes, female sex and female patients with migraine, they tend to progress very rapidly. High IOP, pseudoexfoliation is also a big risk factor. Presence of disc hemorrhage and presence of recurrent disc hemorrhage is an indicator that this patient is going to progress. So in such cases, the lower IOP is planned, and in such cases, we have to lower the threshold for the surgery. If the other eye has lost vision because of the glaucoma, then in such cases also we should have to lower the threshold of surgery. And if there is family history of blindness because of glaucoma, that is not that necessarily is an absolute indication for doing early surgery. But then we have to follow those patients very carefully and plan surgery whenever we feel that the patient is going to have a difficult vision. So indication for surgery is when your optimum medical therapy and laser therapy fails to control the IOP and the condition is progressing. If the patient is not able to comply with the therapy, it's difficult to follow the patients, and if patient cannot afford a medical treatment, that can also be indication of performing a surgery. So surgery can also be planned on the basis of socio-economic status and logistical constraint. Patients who are not willing to use medical therapy and they are not compliant, in such cases, patient surgery can be tried earlier. Thank you. With that introduction, I would like to introduce Dr. Sagar to start his talk. He's going to talk about trabeculectomy. So I'll invite Dr. Sagar to share his slide, and I'm stopping my, yeah. So welcome, Dr. Sagar.
Yeah, thank you, Prashant. Let me just open my slide. Right, so is my slide visible now?
Yes, it's visible.
Yeah, so at the outset, I thank Prashant for including me in this course. And so let me start my presentation with this overview printout of a 25-year-old juvenile open angle glaucoma patient. Is one-eyed actually, and had a trabeculectomy done about 8 years back in his only seeing eye. And at present, patient is maintaining a IOP of around 10, and you can see the stability of visual fields over the past 7-8 years. A wonderfully stable visual fields. Now, what this stability has done to him on the personal front is that he has got a job. He is now married also. So trabeculectomy is a procedure that can be vision saving as well as it can actually enhance somebody's life. So you can have a huge impact by this surgery. So in next few minutes or so, I will be discussing some important tips and tricks of trabeculectomy, which will help somebody who wants to start the surgery or somebody who's into early stage of glaucoma practice. So as we all know, when we talk about glaucoma surgery technique or trabeculectomy, it's not at all standardized, and there are so many variable techniques that are there. And with variable techniques come variable results. So you get different types of blips, different outcomes. So that is a problem. So at the moment, the stage is like this, that whatever level of expertise you have, you still cannot predict what is going to be the outcome on the day one of a trabeculectomy surgery. And that's what makes it very, very exciting surgery to do. So when we do this surgery, the aim of the surgery is to essentially maintain to get basically a very low diffuse bleb, try to get a target IOP which is without medication, and as far as possible, avoid collateral ocular damage. The principles remain that you should avoid sudden decompression anytime during the surgery. On table, you should do a meticulous suturing and avoid hypotony. And it goes without saying that the tissue handling has to be very gentle. So let's start with the preoperative consideration that one has to take. So whenever you are planning surgery for these patients, it's preferable to avoid prostaglandin analogs and pilocarpine a week prior to the surgery, because we know they are pro-inflammatory and they will induce big inflammatory response post-surgery. Try to quieten the ocular surface. A week of soft steroids like fluoromethanol can always help. Anticoagulants, antiplatelets have to be stopped before the surgery in consultation with the physician. And if you're doing a secondary trap, you need to basically look at the conjunctival mobility by using this cotton tip applicator and try to see which zone is relatively free, which area of the conjunctiva is free. And hyperosmotic agents, yes, they have a role, especially if you're dealing with angle closure glaucomas or if the patient's IOP is very high to start with. So these agents like mannitol will bring down the pressure just before you start the surgery. So coming to anesthesia, so there are different ways of giving anesthesia. I prefer to give posterior subtenons because it gives me mobility during the surgery. But peripulmonary anesthesia probably is the most common anesthesia. What we have to remember are 3 important points: that you should avoid excessive volume. You should avoid vigorous massage, and preferably use lignocaine without adrenaline, because it can compromise blood supply to the optic nerve and can compromise the optic nerve damage further. One of the indications for me in peripulmonary anesthesia, if you have extremely deep set globe, so adding volume behind the globe will bring the globe up and it'll make things ergonomically better. So this is how I usually give anesthesia. When I made with the conjunctival opening, I just take a 27 gauge cannula, which has a blunt tip, and just go behind in the subterenous plane and inject about 2 to 3 ml of lignocaine, which is without adrenaline. And basically what it does, it helps in a rotation of the globe, so that, and I don't give it in the inferior quadrant because I want the inferior rotation to happen for me to have a better exposure. In case you are giving anesthesia, obviously you need to fix the globe. Either you can do it with a superior rectus brittle suture as shown here, or one can give a 6070 Vicryl or nylon or silk suture 1 millimeter anterior to the limbus, and one can then use this as a traction. So the next important thing is a conjunctival opening. So you need to decide which zone, which area of eye you are going to do the trabeculectomy. So either superior nasal or superior temporal quadrant you should decide, and you should keep adequate space for a future surgical need. So here we are doing a conjunctival opening with the help of Westcott Caesar, and we are trying to go very gentle, and then you basically dissect in posteriorly and create a good pocket so that you, if at all you're using mitomycin sponges, you can easily accommodate them. And the cautery that we need to do has to be gentle, because excessive cautery will lead to scleral fibers contraction and subsequent difficulty in closure of the wound. So the next step is scleral flap creation. Again, there are different ways of doing it. So here we see a triangular flap being created, and I usually use a 11 number blade, and then use a crescent to create a plane. And the thickness of the flap is important. It should not be very thin. Then there is a risk of flap tear, or it should not be very thick, which will lead to a premature entry. So here we have created the flap, and as you lift up the flap, you can see the clear cornea thing there, and you basically dissect up to the clear corneal space. And then the other way of doing it is to create a rectangular flap, as we can see here. And it's again a 4 millimeter approximately tunnel that you are creating, about 3 millimeters from the limbus, and you essentially tunnel it out. And at this point, then you take a scissor and cut it on the sides, and that creates a flap. And in this crescent makes a very, very smooth intersurface. And next you come to the mitomycin C application. Now, mitomycin C application is a very common thing that we do, and you need to take a decision about what concentration of mitomycin C you will do based on the risk factors, and you should take the decision beforehand. This is how you would make it, and essentially you use polyvinyl alcohol swaps because they tend to disintegrate less, and you try to avoid touching the margins of the conjunctiva, and you place it as posterior as possible and over a large area. So placing it over a large area will make sure you get a diffuse bleb. And the time can be between 1 to 3 minutes, depending on what your protocol says. And once you have done this, you need to, when you finish this, you need to bring out the swabs, count it before you're putting it at the time of putting it, and it's very important to count it when you're taking it out. And once you've taken it out, you need to do a thorough wash. Now, sponge count is very, very important, and you have a look at this survey which was done very recently, where glaucoma specialists in UK and Ireland were asked that, have you ever had a retained MMC sponge and fragment of sponge left in the eye? And I was surprised that almost 12% replied yes. So it is quite common than what we think. So the leaving a sponge is a very, very distinct possibility. So you have to have a very strong suspicion about the sponge, so maintain the sponge count. The other issue with the topic, the sponge mitomycin application, is the variability of the outcome. So here, what we have seen that you can get an absolute flat bleb to a white, what we call it as a white bone. So with the same surgeon, same sponges, same duration of application. And why does this happen is because the sponges that are prepared, they deliver different dosage of mitomycin for the same surgeon or across different surgeries. So that is the problem with the sponge application of mitomycin C. So all these difficulties has made me actually to shift to what is we call it a subconjunctival mitomycin C, which is also not, which is very simple to give. Actually, it's just given as a 0.1 ml solution on a tuberculin syringe with 30 gauge needle, given about 9 to 10 millimeters away from the limbus. And you basically, once you have given that, you use a cotton tip applicator to block the exit and basically roll this bleb of the injection posteriorly away from the limbus. So this basically ensures uniform application of the mitomycin C, And the most common use concentration is about 0.1 milligrams. And this is the way you make the solution. So basically, you dilute the mitomycin C with lignocaine. So if you have a zero point 0.4 milligram per ml ready, you just have to add 0.3 milliliters of lignocaine, and that will give you a 0.1 milligram per ml thing. And once you have done the mitomycin, then you go in with your routine surgery, and you use a pre-placed suture here. Pre-placed sutures are important because once you have done the sclerotomy, you would want to close the globe as soon as possible to avoid prolonged hypertony on table, because that can give rise to cascade of problems like choroidal detachment and other issues. So a pre-placed suture is always a good idea. And then you, before making the sclerotomy, you have to do a small side port entry, which has to be a little long and a small entry, and which will allow a very regulated release of aqueous from the anterior chamber. And this will ensure that when you're doing a sclerotomy, there is no sudden decrease in IOP. And again, that will prevent, especially in patients with angle closure glaucoma and small eyes, it will prevent complications like suprachoroidal hemorrhage. So, and post surgery, this same port can help in deciding about the flow from the flap by injecting BSS. Now, before we do trabeculectomy, let's look at the anatomy of the limbus, and this is very important because what exactly are you cutting? You have to know this. So when we talk about anatomy of the limbus, there is something called as a surgical limbus and an anatomical limbus. What you are seeing is the anatomical limbus, and if you impose surgical limbus on that, so there is something called as a mid-limbal line, which is essentially a junction of the gray and the white portion of the limbus. And 1 millimeter in front of it is the anterior limbal line, which passes through the termination of the Bowman's membrane. The mid-limbal line passes through the termination of Desper's membrane, and 1 to 1.5 millimeter posterior is the posterior limbal line, which touches the scleral spur. So when we remove the block of trabeculectomy tissue, basically you are entering from the cornea, you're removing part of the corneal endothelium, corneal tissue. Majority is that corneal tissue only. Some part of trabecular meshwork does come in, and if you go very posteriorly, you might actually have some part of the skeletal tissue. What is advisable is that don't go very posterior, because then you can come very close to the scleral spur and to the root of iris, where there is major blood vessels around and there is a high risk of thing. So this is what I was mentioning. The junction between the gray and the white zone is the mid-limbal line. Just behind that is the trabecular meshwork, and 1 millimeter in front is the anterior limbal line, and 1 millimeter posterior is the posterior limbal line. So once you make the flap, you can see this, the gray zone is the zone of cornea as well as some part of the sclera. So you don't want to enter on the white portion of the eye, which is basically the scleral tissue. And the more posterior you go, there's a chance that you will end up in bleeding and ciliary body injury. So this is the stroma correction, and let's see how the stroma is being made. So here we have So here we have done the entry with the side port and knife, and then there are ways of making it. I prefer it with the Kelly sponge. And stay at this point, I am not going to posterior. I'm just removing this block, and around 1.5 millimeter of opening is sufficient. And what you see then is the iris there, and then you just have to pull on the iris and do a peripheral iridectomy. And then you have to wash it to remove the pigments that come there and make sure that the iris opening is patent. And then comes the releasable suture. Now, releasable sutures are really a boon in trabeculectomy surgery, because a lot of centers don't have organ suture devices. So you can put in as number of releasable sutures as possible, titrate it on table. Like here, we have put one releasable at the apex, and there you can still see that there is some flow there. So essentially, then you can go ahead and put another releasable at the base. So there are times, in majority of my cases, I have almost 3 releasables, and I can remove them as at my will, and whenever I feel that there is a little underfiltration. So the point here is that on table, it doesn't matter if it filters that much or not, because you always have a control after the surgery. But if on table is leaking too much, then there is a problem of hypertony in the post surgery, which is difficult to manage. So here we have put 3 releasables, and this is how we do put releasables in a rectangular flap. You essentially put 2 releasables at the thing, and you basically want the flow to happen between these 2 releasables. And then we come to the conjunctival closure, and here you basically put a box suture, and this is how you close it out. The disclosure is very important, because you don't want any leaks in the post-op period. That can still happen. And here is the matrix suture that we take on one of the essential incisions, and you ensure a complete closure here. You can also take one central box suture anchoring the conjunctiva to the cornea in the middle. That will ensure that the flap doesn't recess back. And that's how the post-op outcome comes with a standardized technique. You tend to get more of posterior blebs, and they are quite diffuse. And let's see some problems of trabeculectomy. So here we can see a flap being made, and I noticed that there is some the flap has become a little superficial. So in fact, at this point, you can see that there is a little bit of flap tear. So how do you handle this? So you continue dissecting it at a different plane, and you do trab on a little eccentric side, and at the end you just have to suture the flap tear, and the thing gets managed very well. So this is another case who had an angle recession glaucoma, and you can see that there is a corneal opacity which happened because of the side port entry into the anterior chamber. So unfortunately, the eye was dilated that day because of the mistake, and the pilocarpine did not work. So that happened. So this can happen. So luckily, we were lucky in this case that it did not progress. This is a patient who is a patient of eye syndrome, and as we were doing the tunneling, so here we are seeing the other side of the tunneling thing. We have gone very deep actually. So you can see the flap is quite thick. And when we lift the flap, we see that we have already entered the anterior chamber. So there's a premature entry. Now in this scenario, nothing much has to be done. Your entry is already there. You just have to regularize that entry and do a PI and close it off, because you will anyway get the leakage from this point. So this patient had operated about 6 weeks back, and she's actually doing very well. This is just a 30-year-old lady who had a very high pressure to start with. Sometimes you are faced with this issue where the iris kind of pops out, and you wonder what to do. So at this scenario, if you do PI, there is a high chance that you might make a very big PI than what you would like to do. So best is to, in this scenario, is to kind of reposit the iris and then do a PI. So here we can see that I'm using iris spatula, bringing it down, and then do a regulated PI on the iris in the standard way. So these are some of the things that we need to take care. Prashant also asked me to speak for a few slides on trabeculectomy. So I'll be speaking in the next 2-3 minutes about trabeculectomy, phacotrabeculectomy. We all know that phacotrabeculectomy is single site procedure or a 2-site procedure. Now, single site procedure has an advantage that you can do it in very fast, because it's the same opening you use for phacoemulsification as well as for trabeculectomy. But the chance of regulating it post-operatively becomes less, because they tend to have more inflammation at that site and chance of failure is high. So most of us do actually 2-site procedure. Here, everything is the same. You basically do a temporal clear corneal incision. What is important is that the clear corneal incision has to be sutured before you proceed for the trabeculectomy. Now, when you decide about phacotrabeculectomy versus plain trabeculectomy, one has to understand that plain trabeculectomy will give you a better success outcome, better bleb height, higher, but there is a high risk of complication, and 40 to 50% will eventually develop cataract over a period of 5 years in these patients. But with phacotrab, you have a decreased chance of success. The bleb may not be very high, but there is a higher risk of complications due to cataract surgery, and that can lead to failure. And you can have early post-op complications like overfiltration and flat chamber, which are quite rare compared to a plain trabeculectomy. So when you do phacotrab, you should go in for a higher MMC concentration. You should have a lower threshold for removing releasables, and you should be giving more 5FUs. And in a senile age, if you have angle closure glaucoma, it's always better to combine the two. And if you don't have too much of cataract, it's better to look for pre-cataract changes and advise combined surgery, especially if you're doing for a primary open angle glaucoma. Now, in some patients, the main concern is to control the IOP, and it's a very complicated cataract surgery. So it's better to do a trap first and then do a phaco. Like this case had a significant zonular weakening all around post trauma, and we can see that here when I'm taking up this patient for trap only, because considering that phaco would be difficult. So when I was doing the trap, you can see that the vitreous has come from the main wound, and we are doing a vitrectomy here. So this case, anyway, with the vitrectomy and everything went off well. The iris was back to the normal levels. And most importantly, the pressure got controlled from levels of 50 to settle to around 15, 16 with a successful trap, in spite of vitreous prolapse there. So this case, later on, we did a phaco surgery in a more controlled way. after 3 months, and with the CTR and everything in place, this patient did well after the cataract surgery. So sometimes you have to make that decision. Just a small case showing a one-eyed lady who first comes to you with a biarcuate defect like this and a bipolar notch. Don't jump to phacotrap immediately. What you can do is you can do a DVT, see what is the level of pressure, see if you can reduce the pressure by 30%. And then if you're able to do that, you can just go in for do a cataract surgery and then keep a patient under watch. So it's not that you cannot do a trap later on. You can always do a trap if your target pressure is maintained with thing. So another lady who had primary open angle glaucoma on 3 medications. A lot of times, practitioners who are general practitioners, not glaucoma surgeons, don't want to fear with this thing, what is called a split macula, and then they just advise phacosurgery. So just a precaution here, because a wipeout phenomena, we know the factors which are important for a wipeout phenomena are here, of which post-operative IOP spike is one. So in such a scenario, we would always want to combine phaco and trap, because this will prevent this IOP spike and reduce the chances of wipeout. And wipeout phenomena is not that common, because this has been shown in a study by Dr. B. Shanta, where they did 65 eyes with split fixation, phaco or phaco trap, and none of the eyes lost any vision. So I would conclude by saying that one should follow all the principles of trabeculectomy, and that will definitely give you a very predictable outcome in most of your cases. Combining trabeculectomy with cataract removal is a decision that should be individualized. Threshold for lens removal is low, especially if one is dealing with angle closure. I thank you for your patient hearing. Thank you.
Thank you so much, Sagar sir. That was a great talk. Do we have Dr. Devashish Chakravarti? I would like to introduce Dr. Devashish Chakravarti for our next talk. He'll be talking about management of childhood glaucoma. Welcome, Dr. Devashish. You can start sharing your screen.
Yeah, thank you, Prashant, for including me in this IC. So I'll be discussing about the surgical management of childhood glaucoma. As we know, managing childhood glaucoma is challenging, and the definitive treatment of primary congenital glaucoma is surgical management, and medical management acts only as a bridge till the child is not ready for surgery. Now, various modifications to the traditional angle and non-angle based surgical procedures have been introduced in the last 3 decades. And as life expectancy is longer in the pediatric population, the longevity of the treatment choice is crucial. So the decision to proceed with angle surgery is often made during an examination under anesthesia. And if both the eyes have uncontrolled glaucoma, then we prefer to do bilateral surgery so as to avoid or reduce the anesthetic risk. Now, let us see what are the surgical options. The conventional surgical options are number 1, procedures that enhance the innate aqueous outflow pathway, that's the angle surgery. This includes goniotomy and trabeculotomy, or procedures that create an external aqueous outflow like trabeculectomy and glaucoma drainage implant. We also have combined trabeculotomy with trabeculectomy, which is a preferred surgical option with the type of glaucomas that we see in India and the Indian subcontinent. And for refractory glaucomas, we have the cyclophotocoagulation procedures. Now, over the last few years, each of these procedures have seen various surgical modifications. Like for goniotomy, there is now 2-side goniotomy, viscogoniotomy, a specialized blade like Kahug blade, and endoscopic goniostomy. For trabeculotomy, we have external trabeculotomy using suture, or 360-degree trabeculotomy using illuminated microcatheter. We also have gonioscopic assisted trabeculotomy. Then for trabeculectomy, there are mitomycin C enhancement. And for glaucoma drainage implants, that will be discussed by Prashant subsequently. And cyclophotocoagulation, in addition to the conventional transscleral, we now have endoscopic cyclophotocoagulation also. Now, what are the special features of the child's eye that makes the glaucoma surgery challenging? Anesthetic risk, small palpebral aperture, the sclera is less rigid and often thin. This is very important. Corneal clouding, distorted anatomical landmarks in an enlarged eye, narrow anterior chamber, post-operative monitoring. Surgical training is very important, because specialized glaucoma surgery is done in only select few centers, and surgical training one has to obtain in these centers only. And occasionally, or in many of the patients, they would require subsequent surgeries. Now, what is the initial choice? Initial choice is always the angle surgery. So angle surgery includes either goniotomy or trabeculotomy. Both have their staunch advocates, and either procedure have been proved better than the other in primary congenital glaucoma. Now, this is a very high success rate. There is almost 70 to 80% success rate in infants presenting with primary congenital glaucoma between 3 to 12 months of age. Angle surgery can also be used in some other forms of surgery, but remember, the first surgery has the best chance for survival. Now, what are the differences between goniotomy and trabeculotomy? Goniotomy avoids a postoperative conjunctival scarring. It's a faster procedure and less trauma, but trabeculotomy can be done even if the cornea is cloudy. And then subsequent choice is either trabeculectomy with mitomycin C or the tube shunt implants or the cyclodestruction. Now, the basic procedure of goniotomy is that the angle is visualized with a surgical gonioscopic lens, and the needle or an appropriate blade is passed across the anterior chamber, and a superficial incision is made in the trabecular meshwork. Now, there is modification of this trabeculotomy by using this Cahook dual blade, which removes a larger area of the trabecular meshwork and in a more controlled fashion. Now, the basic surgical procedure of trabeculotomy is like trabeculectomy. We create an external flap, then identify the Schlemm's canal, and then introduce the trabeculotome, which can either be rigid or which can be done with the help of a suture, or which can be done with the help of an illuminated microcatheter. And combined trabeculectomy and trabeculotomy, as we have been discussed, is the preferred surgical option in the glaucomas we see here. Trabeculectomy with mitomycin C, similar surgical procedure, just like discussed previously by Dr. Sagar. And then the tube shunt surgery will be discussed subsequently by Dr. Prashant. Cyclodestruction, we know the traditional transcranial cyclophotocoagulation is a procedure that we have been using, but recently the endoscopic cyclophotocoagulation has also been discussed. So I would conclude by showing the two surgical clips. One is the surgical clip of goniotomy, and another is a surgical clip of combined trabeculectomy on trabeculotomy. So this is the goniotomy for congenital glaucoma, and as we can see, the procedure starts under GA, and this is the surgical gonio lens that is placed. There are various types of gonio lenses, like the Barkan lens or the Swan-Jacob lens. And now the paracentesis is made in the clear cornea. So the goniotomy can be done either by a blade or by a knife. And the pupil has to be constricted by pilocarpine or acetylcholine. And it's very important to avoid damage to the lens, and the instrument must be parallel to the iris. And it's very important that the surgeon gets a proper view of the angle structure. So here the view of the angle was not optimal. So the head is tilted. The head is rotated away from the surgeon to improve the gonioscopic view. And now the angle structures now become prominent. So the blade entry is done. If the incision is too tight, we have to enlarge the wound, or else the view will not be optimal. The lens is now reinserted, and the needle is introduced, or the blade is introduced, and the goniotomy is now done. It is a superficial incision, incising the approximately 1/3 of the trabecular meshwork, the uveal meshwork, and on each side the goniotomy is done. So after a successful goniotomy, the angle depends immediately, and the results of the goniotomy becomes apparent in a few weeks' time. But it's very important to remember that gonioscopy can be performed only if the cornea is clear, and most of the congenital glaucomas that we see in the Indian subcontinent, they present with more advanced glaucomas. So in more advanced glaucomas, the procedure of choice is known as a combined trabeculotomy with trabeculectomy. So this has been popularized by many surgeons, and in India, Dr. Anil Mandal from LV Prasad Eye Institute has been the pioneer in this technique. So the basic surgical procedure is that we will show the video. Okay, so after adequate surgical exposure, which can be done either by a superior rectus forceps or by a clear corneal traction suture, the surgical area is now exposed, and the conjunctival incision is done So this is a fornix-based conjunctival incision, just like we do in an adult trabeculectomy. You can see the corneal haziness and the herb striae. So the conjunctiva was dissected. I do not use mitomycin C in the initial procedure in most cases. Now the conjunctival, the superficial scleral incision is made. Remember, in a ophthalmic eye, the sclera is stretched and maybe very thin. And if you exert undue pressure, you can go through and through. So the surgical dissection is now made. It should be a triangular scleral flap or a rectangular scleral flap, but it should be in the same plane. And you should proceed slightly into the clear cornea so as to expose the surgical landmarks. And now the most important step to identify where the Schlemm's canal is. So remember, where white meets blue, Schlemm's canal waits for you. So just at the junction of the sclera and the posterior zone of the green limbus, there's a Schlemm's canal. We make a partial thickness radial scratch incision under high magnification and go gradually deep. Do not exert undue pressure. And when you have the adequate plane, the posterior pigmented, the inner wall of the Schlemm's canal shines through, and a drop of aqueous may come out, like you can see a drop of aqueous, or sometimes a drop of blood can come through, and then only you'll identify this is the accurate plane. Now you should be very gentle in introducing the trabeculotome. So this is a rigid Herms trabeculotome. It has two limbs. The superior limb is to direct you that you are going in the right direction, and you should enter it without undue resistance. And now you make a sweeping movement into the anterior chamber, just parallel to the iris. Do not go too superficially, it can cause a decimal detachment. And similar procedure is being done on the other side now. Again, you can see that I'm introducing it very tentatively so as not to go into the false plane. I would like to enter into the plane where there is minimal resistance. If you're in the right plane, there's minimal resistance. You introduce it as much as you can, and then again sweep it into the anterior chamber parallel to the iris plane. Okay, and then gradually withdraw the trabeculotome. So immediately after successful trabeculotomy, you can see that the cornea has cleared significantly. The central mark is the herb striae that will persist. And now we go ahead with the trabeculectomy part. So we make the trabeculectomy, the deep scleral flap, just like we do in an adult surgery of trabeculectomy with mitomycin C. So we remove the deep scleral block first posteriorly, and then make the two side incisions, and then proceed anteriorly. So most of these children are small children, and you require an expert anesthetist for the surgery to be uneventful. So we now excise the deep scleral block. It should not be too small, and it should not be too large also, so that it should not go to one side. This will cause overfiltration. And now the surgical iridectomy has to be done. So with the limbs forceps, I pull the iris and incise the iris so that the iridectomy that I perform is wider than the internal ostium. Now the scleral flap has to be sutured. So I apply a single 10-0 nylon suture at the apex. In adult glaucoma surgeries, we usually apply the releasable sutures, but in infant's eye, even if the AC becomes shallow, it tends to form normally. We do not need to reform the anterior chamber. In most of the cases, it will form normally, and removal of the releasable suture becomes a problem in children. So if you apply the single apical suture at the apex, titrating the incision, titrating the tightness, then it suffices in most of the cases. So that is the end of the surgery. The last step is to close the conjunctiva. So you have to remember that the conjunctival incision has to be watertight. So I apply 8-0 vicryl sutures at the two ends, wing sutures at the two ends. And I also, if needed, supplement it with other vicryl sutures or other 10-0 nylon sutures, so that the cornea, so the conjunctiva is tightly sutured to the cornea and there is no post-operative leakage. So this is the basic procedure of the combined trabeculectomy with trabeculotomy, which we perform along with an examination under anesthesia. So that is the end of this presentation. Thank you.
Thank you very much, Dr. Debashish.
Thank you.
For a wonderful talk. Really very nice. And one of the difficult scenarios in glaucoma, managing a pediatric glaucoma needs a lot of expertise, a lot of experience, and a lot of skill actually. Thank you so much for
indeed.
sharing this presentation. Yeah.
Thank you. Thank
So,
you.
yeah. So now we will invite Dr. Prashant for his talk on implants. So Dr. Prashant, let me just introduce Dr. Prashant. He's a glaucoma consultant at Netralayam and BBI Foundation. He has done his long-term fellowship and worked as consultant in the Department of Glaucoma in Shankar Netralaya. He's a very well-known instructor and speaker at various international, national ophthalmic forums, and he has many publications in peer-reviewed journal. So let's have Prashant for his talk. Prashant, over to you.
Yeah. Thank you so much, Dr. Sagar, for your kind introduction. So I'll be talking about this. My slides are visible now?
Yeah, it is visible, Prashant. Go ahead.
Yeah. So I'll be talking about the role of drainage implants in the glaucoma surgeries. First of all, I would like to say I have no financial interest in any of the implants or surgery or any techniques. Basically, implant is indicated in cases where conventional trabeculectomy is failed, and the use of basically, implants are indicated in cases where the trabeculectomy is failed, either failed or most likely to be failed. These are the cases of refractive glaucoma in which the chances of success of trabeculectomy is little less as compared to the conventional. So we can directly go for an implant patients. So basically, implants are of two types: valved and non-valved implant. What an implant does is it connects, it is in the form of tube, connects anterior chamber to a subconjugal space. So it drains the aqueous directly from the anterior chamber to a subconjugal space. So there are two types of implants. One is non-valved and valved implant. Non-valved doesn't have any intrinsic system of valve. So aqueous outflow is actually maintained by a development of fibrous capsule which forms over the period. So initially you have to ligate to minimize the overflow of the fluid. And the other type of implant is valve. They have an intrinsic system of valve, so that regulate the amount of aqueous going into the subconjunctival space. So Ahmed is a type of valve implant. This is a valved implant, which is a prototype. It's a large side barium implanted implant, which is a large silicone tube. This is a non-valved implant again, and it has fenestration at the base plate, which allows the fibrous growth of the tissue. So with time, a fibrous capsule is formed over the implant, which helps in providing the resistance to outflow. This is a Molteno implant. It has a plate, acrylic plate, and a tube. There can be a two plates implant also, and V-shaped pressure ridge implant also. Now, the implant which is used by us mostly is the Ahmed implant, is the valve implant. FPA 7 number implant is mostly used in adults. So it has a base plate and a tube, and the base plate has a valve which has a silicone elastomers which collapses when the pressure is low, and so thus it prevents the outflow of fluid. So indication of doing an implant is the case of failed trabeculectomy, as I said earlier, and the cases where trabeculectomy is most likely to be failed, like cases of iridocorneal endothelial syndrome, uveitic glaucoma, infantile glaucoma, Surge-Weaver syndrome, neovascular glaucoma, and glaucoma with PK, post-PK or corneal transplantation, and also certain cases of VR surgery, post-VR surgery, the patients develop glaucoma. In such cases, implants are very much useful. Now, what are the sites where implant? The one big advantage of these implants over the trap, that a trap can be done only in the superior area of the eye, whereas implant can be done also in the inferior. So inferior temporal implant can also be done. Also, we can do a superior implant. So this is a superior temporal implant. Here we have an inferior temporal implant. Implant can also be done in cases we have a extensive thinning of the sclera. So in this case, it's a uveitic case where you don't have a good conjunctiva and don't have a good sclera to support a trabeculectomy. In such case, implants can be used. Now, implants can be put beneath in the sulcus behind the iris, and can, like in cases of post-PK glaucoma, where if we put the implant anteriorly, there is a danger of touching the graft or the cornea. So we can put it in the sulcus, so it stays away from the cornea, so there is minimal chance of tube corneal touch. Now, this is a surgical video explaining the implantation of the how the valve can be implanted. First of all, we mark the area around 3 mm from the limbus, and open a conjunctiva, doing a conjunctivomy, and then peritomy, and then we have to elevate the conjunctiva along with Tennant's capsule. This step is very much important. It's called priming of the valve. It ensures that the complete system is air-free. So here the priming is done. So we can see the gush of fluid here. So priming is done. Now this is a FP7 number of MR glaucoma valve. Now holding the implant gently away from the base plate and pushing it back. The next step is to anchor the valve over the sclera. So generally it is done around 9 meters away from the limbus. So it can be done by 9-0 nylon suture or 10-09 suture. So once the valve is anchored, then we create a paracentesis, and then we mark the size of the tube should be given inside the eye, and cut the tube in the bevel head up direction mostly, so that it doesn't get blocked. If you're putting in the anterior chamber, it doesn't get blocked by the iris. Now, with the 23 gauge needle, we form a track, and through this track, this implant is pushed into the anterior chamber. So now we have an implant inside the AC. So now we are fixing the implant over the sclera so that it doesn't get dislodged with the 10-0 nylon suture. Just it is not ligated here. Just the purpose is just to anchor the implant and support the tube to be in the position. Now this tube has to be covered by a graft. So normally the scleral graft are used, donor preserved scleral graft. We can also use a donor cornea, which cannot be used for PK. And after that, we can suture the conjunctiva, watertight suture with running 8-0 Vicryl suture we can use. So this is how the normally the implant surgery is done. So after once you have done this with the surgery, you have a post-op period in which an implant has initially hypotensive phase for a period of 1 month, where you have a diffuse thick walled bleb. The pressure will be low. But after 1 month or so, the pressure will increase again because of formation of the fibrous capsule. So there will be little inflammation, and the bleb will appear little dome shaped. Once this phase passes off, then you enter into a stable phase where IOP is usually in lower T. There can be certain complications with your implant surgery also. Particularly if you're not using a valve implant, you can get hypotony. Even in cases of valve implant, there might be leak from the edges of the paracentesis or the track that we created. So you can get hypotensive phase initially. There can be tube obstructions like this with the iris. There can be tube exposure. And sometimes the tube retracts, then you have to put explant. And this is a photo showing that the exposure of explant also. So explant can also get exposed. So it is very important to cover that with the graft. There can be cornea endothelial touch, and also there can be ocular motility disturbance, particularly if you're doing it in the superior nasal quadrant. That is why superior nasal quadrant should be avoided, because there is a very little space over there. So you can get a motility disorder. So there are a few examples where implant was very helpful. This is a case of 45-year-old female patient, had a visually significant cataract with IC syndrome, and IOP was 32 millimeter of mercury. You can see the cataract was significant, and patient had IC syndrome. You can see the cells were less. So in that case, the phacoemulsification was done with viscoat cover to protect the endothelium, and the implant was done. And you can see the implant here in the sulcus. So it gives excellent result. We can also do a TRAB in cases of IC syndrome, but generally what happens when we do a TRAB in IC syndrome, we get a very engorged vessel, angular-looking vessels over the conjunctiva, which limits the chances of success in IC syndrome. So we can try doing a TRAB also in IC syndrome, but the success of putting an implant is much higher. Now this is a case of cornea, decomposite cornea, where the implant was done along with the dissect procedure. Here again, we can see it was well placed in the sulcus, and it is away from the graft, and which gives excellent result. So it was done with dissect and AGBS done together. Now, patients with corneal opacity and uncontrolled glaucoma, we can plan penetrating keratoplasty along with the implants, putting an implant together. So which gives excellent result. Here in this case, the pressure was well controlled after 3 months of therapeutic PK. Once you have an implant after penetrating keratoplasty, it may, after some time, the pressure may again arise, may be out of control, and with maximum medication, then you can consider putting 2 implants. So one implant is there in superior temporal quadrant. You can still put an implant in inferior temporal quadrant, which can control the pressure. So 2 implants can also be applied. Now, cases of neovascular glaucoma, as we know, the neovascular glaucoma is very aggressive disease, and the chances of success of trabeculotomy is very less. So in such cases, there are good candidates of putting an implant rather than doing a trabeculectomy. So this is the case of neovascular glaucoma, where putting an implant, so we can see the hyphema here, putting an implant was able to control the pressure. That is why it has gained popularity in the surgical management of neovascular glaucoma. In uveitic glaucoma, because marked inflammation in post-op period, the chances of bleb success is less as compared to other cases. So in such cases also we can put a implant. As I showed in the earlier slide, in sometimes in uveitic glaucoma, the superior sclera and other areas are thin. So in that case, we can also put the implant in temporal infratemporal quadrant. Now, this is another example, which is a rare case. This is 1.5-year-old child who had blue sclera and decompensated cornea. The other eye was thicycle. He had hyperextensible joints and skin. B scan was normal. So this was a case of Ehlers-Danlos syndrome. You can see the vision was hand movement positive in other eye. The other eye is lost because of its thicycle eye. And this eye had 3 PKs already done. The pressure was 32 on tonopin. Fundus result was not seen, but the retina was attached on B scan. So in this case, there is no question of doing other procedure, and there is slight visual possibility in this patient. So we cannot do and also a cyclodestructive procedure was very difficult because the sclera is very thin all around. So to preserve whatever vision the patient had and provide visual rehabilitation, the best was to try putting an implant in this case, which was again difficult because the sclera was so thin all around. Yeah, so sclera was thin all around, along with the conjunctiva was scarred, and 3 PKs were already done. So it was a difficult case. It was very difficult because the sclera is thin, so it was difficult to take even a bite in the sclera. So this was how traction suture was done. Luckily, we had a very healthy conjunctiva, was very good, and tendons were very thick in this case. So that's why we were able to put implant there. And since it was a victotomized, the plan was to put the tube in the sulcus, in the pars plana instead of the sulcus. So it was once the sclera was the implant was anchored to the sclera, it was put, the tube was introduced into the pars plana. So around 5 millimeter, it was the entry was done around 5 millimeter from the limbus, though the limbus was very diffuse in this case, difficult to identify. And then first the residual vitrectomy was done, and then the tube was inserted into the pars plana after priming. So if you are inserting the pars plana, you have to put the tube a little longer because there are chances of blockage of the tube with the vitreous. So this is how the tube was introduced in the pars plana. And then the rest of step was same as before. The graft was covered with the scleral patch. But here again, we cannot suture the graft, so we used we used the acrylic glue to fix the conjunctiva over the graft. This was the post-op result. You can see the tube was in situ. So IOP was well controlled, but there was exposure of the graft in post-op period. So again, the graft repositioning was done. We can, and finally we can see the successful bleb over here. And after that, after some time, the 4th PK was done, and the child was able to see something. At least he was able to walk independently. Now, if we compare the result of tube versus trab, this is a landmark study which included 212 patients and in 17 centers. 107 patients were included in tube and 105 patients were included in trab group. So what was found that both tube and trab resulted in a good IOP control up to 5 years. However, the tube surgery was associated with the more use of glaucoma medications in initial first 2 years of surgery. The cumulative success rate of failure was 29% in the tube group, but very high of around 46% in the trab group. And also the need for reoperation or reprocedure was much higher in the trab group as compared to the tube group. So visual loss occurred as similar in both the groups. So conclude, I can say the tube surgery is a very good technique to control intraocular pressure in patients in which the conventional surgery is mostly going to fail, and also the cases where it has already been failed. And also certain cases, some extreme cases where there is no question of doing an implant, doing a conventional surgery or trap. So the glaucoma drainage implant provides an excellent tool in our armamentarium to control the intraocular pressure in such complicated situations. Thank you so much for a patient hearing. So I think we have come to the end of the sessions. We had one more speaker, but he is not able to join us because of his personal issues. So we have enough time to discuss. Dr. Devashish, you are there? Yeah.
Yeah, yes.
So we can discuss few points regarding childhood glaucoma. So I have a question. First, as you said that mytoma, initially you never used mitomycin in cases of childhood glaucoma. So now I feel now we have started using mitomycin in such cases also. So what is your what are the points that you consider while taking into consideration using of mitomycin, and what dose you use in case of childhood glaucoma?
It's a double-edged sword actually. Always there is a risk of bleb thinning because the child has to live his life. So if you use mitomycin C in the first instance, there is always a chance of a bleb-related complication coming up at any point of time in the child's lifetime. So if it's the first surgery, and if the anatomy has been dissected well, you can do the trabeculotomy well and the trabeculectomy well, then mitomycin can be avoided. So that is one school of thought. But of course, if you use mitomycin C, then the trabeculectomy part works better and the chance of bleb fibrosis is less. So there are two schools of thought. I think in India we have surgeons like Dr. Mandal from LV Prashad who never use mitomycin C in the first instance, but only if the child requires a subsequent repeat surgery, another repeat surgery with trabeculectomy or trabeculotomy, then he would use mitomycin C. But some other surgeons like Dr. Ramanjit Seota from AIMS, I think they use mitomycin C in all the cases, including the first surgery. So that is two different ways of thinking.
Thank you. And if mitomycin is used in such cases, generally in adult we use 0.4 milligram or 0.2. So what is the dose of mitomycin that you use?
So again, it is a individual choice. I think the concentration remains the same, but the duration may be reduced. Duration may be my standard procedure for adults is 0.4 milligram per ml for 2 minutes. In case of children, if I use in a subsequent surgery, I would use for a shorter duration.
Okay. Okay. And sometimes we get a very thick tenons while doing pediatric glaucomas, very thick tenons. So what shall we cut or trim those thick tenon, or what should we do? Yeah, a very thick tenon can impair the chance of success, I think.
Yes, particularly in case of juvenile glaucomas, you can find this sort of thick tenons. So if you can actually dissect a little bit, but then again, only that part that is extending beyond the conjunctiva. So I usually avoid to excise the tenons. I prefer to keep it, and I would use slightly higher duration of the mitomycin C if I find the thick tenons.
Okay, and there is no role of reusable suture in childhood glaucoma at all.
It's very difficult. In a case of infant, if you put a reusable suture and then you have again to do a subsequent anesthesia for this child, so it's better to avoid reusable sutures.
Sagar sir, you would like to ask or discuss something about childhood glaucoma?
No, I think yes, covered most of the points, very important. But the question is that childhood glaucoma has to be dealt with skilled hands. It cannot be done by anybody. It needs training, needs assessment, needs knowledge about landmark, tissue handling. Probably it is one of the most thankless jobs in glaucoma because you change child's life by doing a surgery which will have an impact for his life. And as Dr. Devashish rightly said, a well done trabeculectomy, actually after that it doesn't need it. Even a trabeculectomy is also not needed. A trabeculotomy or a goniotomy itself can be just it can be as successful. So we have seen so many such patients, they do well. But what important thing is that when you follow up these children over a period of time, especially this ophthalmic patients, when they are growing, there is a natural progression of the axial length also. So it's very important that you follow their retinal evaluation also, because there are times that they are prone to developing peripheral retinal tears. So in a teenage, early adulthood, when they are maturing. So a peripheral retinal examination is something that we would definitely watch out in these children. That's one point which I would like to highlight. And yeah.
with a success trial in childhood glaucoma, there's chances of reversal of cupping also. So prognosis is very good if it is done in very good hand. So it's better to refer the case to a good surgeon rather than trying. So I have a question for you, sir. That you have, I think, in the case of combined trab and phacoemulsification surgery, you have shifted to two-side technique completely, one side technique. So do you think that two-side is much more successful as compared to one-side technique, and should not be done? One-side technique is completely something which should be avoided while doing a phaco trab?
No, it is not like that. It is purely a individual's choice. I'll tell you what has happened, that we have all evolved as phaco surgeons through a clear corneal incision. And suddenly, if you have to do a phacotrabeculectomy, which involves a scleral tunnel creation and then trying to make an entry through that scleral tunnel and then pushing in your phaco. So there are practical issues there, especially if you are not used to doing a tunnel phaco. When we trained ourselves, we started with a scleral tunnel phaco actually. So it was easier. But what I have realized is that there are times when you do a premature entry, especially when you're doing a scleral tunnel phaco. So that is one of the problems when you're doing a scleral tunnel phaco. Second thing is ability to modify your trabeculectomy post-surgery. So here, because you have a tunnel there and the only opening that you make, so the post-op modulation becomes a little issue. So when you separate the two things, the modulation is like a normal trap. You can treat that patient like a normal trap. And you have to be more aggressive compared to a normal trabeculectomy because you are spending more time on surgery. There are higher chances of inflammation in these patients. So as I showed in my slide, I would be more aggressive in removing releasable for these patients even early compared to a normal standard trabeculectomy. So that's one thing that I would prefer. And other than that, there are obviously there are many papers which suggest that single site success is almost same as two-site procedure. It's an individual choice, individual experience, I think. What do? You do two-site or single site?
If I'm dealing with a case of acute angle closure or something where the corneal status is not so good, then I feel two-side is a safer technique. Otherwise, in most of the cases, I'm still sticking with one-side technique. For difficult cases where we have a very unstable anterior chamber, there doing a two-side technique is of great use. And regarding the use of mitomycin, so we all are using this mitomycin soaked sponges to apply mitomycin in the subconjunctival area. So recently few people have shifted, and you also shifted to a technique where you give a diluted concentration, which provides a consistent dose in a wide range of subconjunctival space. Right. So do you think it is giving a very good bleb outcome as compared to the sponge-based application of mitomycin? Yeah.
It's consistent, I would say. It's consistent. And main thing is that I get more diffuse blebs post subconjunctival mitomycin as compared to mitomycin sponges. The reason why sponges has an issue is because you cut sponges in variable thickness. See, and every time you have a new assistant with you, the way he cuts it, the way he soaks it, basically leads to a very variable concentration of mitomycin application. So that's what actually perplexed me a lot as to why one mitomycin bleb is so white, the other one has actually as if you have not applied anything. So that made me actually shift to a subconjunctival mitomycin where I have the control on as to what area I want the mitomycin to add. And it is, and there are so many publications now. I think there's one publication from Arvind also recently, which has come up in IGO, where they have spoken about these technique of subconjunctival mitomycin C being comparable to mitomycin sponge, and why would I now take additional risk of sponge, residual, those things. So that has made my technique to change now. Well, almost last couple of years, I've shifted to completely subconjunctival mitomycin.
So you use a 30 gauge needle to introduce the mitomycin over there?
Yeah, on a tuberculin syringe, yes. Yeah. And what happens is, an additional benefit is that you are giving lignocaine also. So a little bit of anesthesia is also kicks in by the time you do a conjunctival flap. So in my technique, I don't do any perivalvular anesthesia at all. So when I am giving this injection, I am actually giving in mitopycin along with lignocaine. So some amount of anesthesia also kicks in before actually I make a conjunctival flap. So once I make the congenital flap, I definitely go ahead and give a 2 ml of posterior substance from there itself, and then continue with my trap.
And what is the ideal way of titrating the mitomycin concentration? What is going to apply on a particular patient? Like you have a patient of open glaucoma who doesn't have much inflamed conjunctiva, and you feel that a mild dose of mitomycin would do and suffice in this case.
Correct.
So how do you titrate? Whether you dilute the concentration, you use it 0.2 instead of 0.4, or you decrease the duration of the
application? In subconjunctival mitomycin application, we never give 0.4 because that's too high. So it's either 0.2 in high risk cases, or it's 0.1 in most of the cases. Because somehow, but the thing is, of course, with respect to the risk factors that you would think that are responsible for failure. For example, if you're dealing with a neovascular glaucoma, or the case which I showed was an ICE syndrome girl whom I did a trap with the mitomycin. So there I used 0.2. So basically you do preclinical assessment. And as I told that this concentration is decision based on your assessment of the risk of failure for that patient. So if you are doing a retrabeculectomy is again a chance that the chance of failure is high. So again, you would use a little higher concentration of 0.2 would be suffice for these patients. But if you're doing in a patient whose conjunctiva is fairly untouched, or there's not too much of a medication used in that patient, then you would go in for a lower concentration of trap. So it's purely a judgment which you take based on the chance of failure that you expect in a patient. I think that same thing holds true with the mitomycin sponge application also. You take a decision based on what is the chance of failure, risk of failure, high risk of failure.
Devashish would like to add something. Would you like to add?
Yeah, so for phacotrabeculectomy, most of the cases I prefer a two-site procedure, mainly because most of us are accustomed to the temporal clear corneal incision. So I would not like to change my usual surgical style while doing a phacotrabeculectomy. And particularly in cases of, you have many patients who have deep set orbits, who have been on prostaglandin analogs for a lot of period of time, and they have prostaglandin-induced periorbitopathy. So there also, if you do the phaco to the temporal approach, it becomes easier. So that is one thing. Regarding the mitomycin C, I still use the mitomycin C soap sponges. And what I've observed is if you put multiple small sponges rather than big size sponges, and you put them interiorly, so they should not come close to the limbus. For that, you have to make an incision as far posterior as possible, the conjunctival dissection. Then in most of the cases, you can avoid this bleb-related complications. They are more in case of this limbus-based flaps. So it's a limbus-based flap where there's a posterior, like a ring of fibrosis that will keep most of the mitomycin C anteriorly, and that will cause most of these thin blebs and overhanging blebs. So I prefer to do a phonics-based flap, and I dissect very posteriorly. And I also take care to put the mitomycin C sponges quite away from the limbus, so that the anterior edge of the conjunctiva is not in touch with the mitomycin C. And most of these patients, actually, they have good blebs. We can avoid the thin blebs, except in myopes. In myopes, I am very careful and I reduce the duration of mitomycin C. I keep the concentration of mitomycin C constant because the assistant will make it, and she will probably find it easier if she follows the usual thing. But I reduce the duration of application if it's a myope or it's a very thin sclera due to some of the reason. But I guess this injection of mitomycin C is a very good technique also, and if you're comfortable with it and you find better results, you can always do that.
Any contraindication of not using mitomycin at all?
So I use actually mitomycin C in all cases. In very high myopes also, there's always a risk of failure of the glaucoma surgery at the back of my mind. So I use it at least for 1 minute or so. And small sponges, and I take very care to wash it away. So unless it's a pediatric glaucoma surgery, like we've discussed, is the first trab I avoid a mitomycin C. Otherwise, in all glaucoma surgeries, be it trab or phacotrab, I do apply mitomycin C.
And do you use in post-op period? Do you use 5 fluorouracil injections in case of
no? No, I don't use 5-FU. If at all needed, I do a blade needling with mitomycin C.
With mitomycin C again. So there you inject mitomycin.
Yeah.
Okay. So I think we can close the session now. We are before time, but we can close the session now. I think we have anything more you would like to add, Dr. Sagar, Dr. Devashish?
I think most of the points are covered very nicely.
Yeah.
Most of the
We
things
can
are
close
covered.
the session. So
Yeah,
over to you.
Thank you so much, sir. I appreciate that you have finishing it before time, sir. Like much before time.
Yeah, because one speaker could not join because of personal issues.
Yes, sir.
We have enough time left.
I thank you so much, sir. I thank all the speakers for the wonderful presentation, and this was an amazing session.
Thank you.
Thank you.
Thank you.